And now on to Dr. Nick Nguyen. He's our editor, chief communication officer, and he'll be introducing our speaker, the star of tonight, Dr. Audrey Yoon, who will be discussing the role of orthodontic intervention in sleep disorder breathing, functional and physiological approach of orofacial structure restoration. Thank you, Nick, and the screen is yours now.
Thank you very much, Dr. Yang. It is my pleasure tonight to introduce Dr. Audrey Yoon. She was kind enough to come and speak for us 2 years ago at our occlusion, TMD, and sleep apnea full day symposium. So we welcome her back. Dr. Yoon is a graduate of UCLA Dental School. She did her orthodontics and pediatric dentistry residency at UCLA. She completed her Master of Science degree with extensive research in obstructive sleep apnea at UCLA. And she's currently the clinical faculty also at UCLA. She has a wonderful lecture for us tonight. So with that, I'd like to welcome Dr. Audrey Yoon.
Hi, everyone. It's my honor to present for Santa Clara County Dental Society. Thank you so much, Dr. Nguyen, for a wonderful introduction and invitation. I do not have any potential conflict of interest to disclose. A little bit about me. I'm a pediatric dentist and orthodontist. Currently, I'm affiliated with 5 different universities and teaching 4 different specialties. My passion is raise awareness of sleep disorder breathing in each specialty and push the mainstream scholars to open their heart and work together to move this field to the next level. One of the exciting things, you guys are local, that I'm establishing the dental sleep medicine clinic in the Department of Stanford Sleep Medicine in the Redwood City, where I teach the sleep physicians, sleep medicine physician about what dentists can do, and then we're gonna see the dental patient together. Another exciting thing was that we finally created the first university-based pediatric dental sleep medicine mini residency at Tufts University. So we put the world's best leading speakers and try to establish the evidence-based pediatric sleep medicine protocol and curriculum, including hands-on workshop. And I am actually so excited actually to see the change of our residency program curriculum. So today I'm here, I'm at UCLA. I ran the dental sleep medicine course for our resident. Now it's a combined program with the UCLA, UCSF, UOP also resident, and UCLA pediatric resident, and it's a 1-year ongoing the program where our resident will be very well educated. We are so lucky. The California residency are just really ahead, and especially the UOP is definitely the world leading orthodontic program. We studied the dental sleep clinic on the orthodontic department, and where our residents treat the sleep disorder breathing patient in our clinic. I mean, due to COVID, we had a little 1-year break, but we did have a rotation program between UOP Ortho and Stanford Sleep Surgery, where our UOP Ortho residents join our sleep surgery clinic to see how we examine, evaluate, and come up with a treatment plan. And they also come to Stanford operating room to see how sleep surgery gets done and follow up the post-op cares. So Stanford Sleep Surgery is very open to collaborate with you guys. So if you have any expansion surgery case and any surgery cases, please feel free to work with us. I also have multiple private practice. My main office is actually in Southern California. One is in LA. I am LA Clippers orthodontist. I have a lot of Clippers players and cheerleaders as my patients. So hopefully after the COVID better, if you guys want to go for the basketball team, you just let me know. I also have ortho-pedo practice in Bellflower, where we see a lot of pediatric, early interceptive ortho practice. And also I have a 2 satellite office in Northern California, in Daly City and Redwood City. So why sleep? We all know sleep is important, but still most of sleep apnea is undiagnosed and cause health crises. Sleep apnea is responsible for #1 motor vehicle accident, not drunk drive, and also workplace accident. And it reduces your work efficiency. And obstructive sleep apnea also contributes to serious health consequences such as heart attack, stroke, AFib, type 2 diabetes, memory loss, and so on. Now we live in this strange COVID era. So OSA is also increased the COVID infection, hospitalization, and mostly like respiratory failure. And their odds for respiratory failure of OSA is worse than obesity. And also, I hope you guys already got all the COVID vaccine. The top chart is the sleep-deprived subjects antibody reaction to vaccine. If you compare to the lower chart of control, you see sleep deprivation also affect your antibody production to vaccine. And also we talk about this CPAP. CPAP, continuous positive air pressure machine, is the gold standard of sleep apnea treatment, but it spread airborne infections such as COVID-19 by aerosolizing the virus. So sleep medicine field last year was like really upside down, and they've been changing like any other business, and they're looking for direction of new modality, and dental treatment is actually one of the treatment that they're really looking at as an alternative treatment. And most importantly, within the past decade, there has been increasing awareness of OSA and its consequences among the orthodontists, especially the role of dental and orthodontic profession in screening and treating sleep apnea patients. And I believe the orthodontist and dental profession play a key role in diagnosing sleep disorders, since we tend to be in contact with our patient more frequently than other health professions. And in our interest as orthodontists, malocclusion is very related to sleep. Because malocclusion can be a sign of other medical conditions. And maxillofacial and alveolar bone structure sometimes tells you the story why they have been formed in such way. On surface, you may just see the malocclusion such as narrow, high-arched palate, retrognathic mandible, vertical growth patterns such as open bite, but it could be a signal that patient may have nasal obstruction, mouth breathing, abnormal tongue postures, sleep disorder breathing, TMJ dysfunction, myofunctional dysfunction. So this is my rough scheme of a current OSA treatment protocol. If the OSA patient come to my office, first I see they are growing patient or non-growing patient. If the patient is already grown up, currently the gold standard is using CPAP or oral appliance therapy. And if they are not enough or the patient doesn't like them, then we refer to the sleep surgery. If the patient is a growing child, then current gold standard is doing adenotonsillectomy, the surgery. However, adenoid and tonsil are small, or there is some residual OSA after surgery, then we plan growth modifications such as maxillary extensions. So oral appliance therapy, sleep surgery, and growth modification are the area where we can play an important role of OSA treatment as a dentist. So let's talk about the growth modification a little bit. The awareness of growth modification are definitely there, growing in medical field, not just the dental, but in medical sleep medicine field. This is a new editorial paper, February last year at the Sleep Medicine. They talk about adenotonsillectomy has a good short-term effect, but there is a lot of residual OSA, and they proposed the rapid palatal extensions, use of oral appliance, and myofunctional therapy as so proposed other treatment. When we talk about the growing modification, I have to mention my mentor, Dr. Christian DiMamino. Past years, his passion was to look for preventive treatment for sleep apnea. He has pressured me personally to come up with a growth modification protocol for children. And we still don't have much evidence in this area, but I think it gives some guidance and grounds how we can proceed and build more evidence from here. Because we think that sleep apnea is just like a big fat old man as he did, but you have to really watch out the little kids that we actually can change their lives. The common symptom of pediatric OSA is snoring, and the pediatric the mouth breathing and bruxism. And some kids are sleeping in odd position where their neck is hyperextended like this, or this is what we call the in yoga position child pose, and the yoga position that their butt sticking out. Sometimes they have to do this posture because they want to open up the airway. And also our kids is different from adults. Adults, especially the men, if they don't have enough sleep, they just get sleepy. But for our kids, if they don't have enough sleep, they get hyperactive. Like they act like ADHD, they have a behavior problem, they get cranky and frustrated, and they get some school problem. Also, the bedwetting is one of the symptoms of OSA. And some kids just get frequent ear infection and they get ear tube placed, or frequent tonsil and adenoid infection. They are all related to OSA. Among these symptoms, I like to emphasize the ADHD because the ADHD symptoms are widely overlapped with the sleep disorder breathing. And some child may get the misdiagnosis with the ADHD when what's causing his symptom maybe really be a lack of sleep. And many studies show that ADHD symptoms get improved after sleep disorder breathing treatment, such as adenotonsillectomy. So we should screen sleep disorder breathing and treatment of sleep disorder breathing first before giving ADHD medication to our kids. A lot of the parents also ask how sleep apnea is connected to the bedwetting issues in neurosis. So there is actually 3 mechanisms. The first is the dampening effect of OSA on the arousal response, and second is a change in bladder pressure, and then number 3 is secretion of the hormone involved in fluid regulation. So imagine that if there is an airway obstruction, that makes the children work harder to breathe in, which increase intrathoracic pressures, which increase the intra-abdominal pressure, which increase the bladder pressures, and that alter the secretion of a hormone that regulate the fluid balance, ADH, so we call antidiuretic hormone. And if decrease the nocturnal secretion of ADHD, result in the bedwetting. And also, if there is a less oxygen from the poor breathing, that will cause the heart to produce more ANP peptide. And this ANP peptide will cause the kidney to produce extra urine at night, and then our kids get the mistake, get the accident. This is something that we need to think about. Sleep disorder breathing has a large spectrum from mouth breathing, snoring, upper airway resistance syndrome to the severe form of obstructive sleep apnea. However, we think that it is a continuum and progressive spectrum. The currently US medical insurance covers sleep apnea treatment only from after you get diagnosed sleep apnea. So only from here. But if our children are in early spectrum, are we gonna wait until it gets worse? If not, then when is a good time to intervene? It is like always question. So when we talk about the orofacial growth modification, we have to see, do we really need to intervene or not? Then when to intervene, then where to intervene, and how to intervene. I thought that this picture was cute. You see the little fetus skull? You can actually fit this fetus skull inside the eyeball of adult skull. It shows how much craniofacial structure can grow. So if we properly intervene at the right timing, at the right structures, maybe we probably can control some craniofacial growth, isn't it? This is one of the most common negative orofacial growth pattern. If there is a difficulty to breathe, then tongue has to come forward and downward to open up the airway to breathe through the mouth. And in order to breathe through mouth will be open, and the craniofacial structure grows more vertically rather than horizontally, which leads to often like open bite, gummy smile, and long face. So if we know that growth modification is very time sensitive and age dependent, and we may be able to change the trajectory of a growth if we intervene in the right timing, we should definitely add orthodontic treatment under the treatment options. So the key to pediatric sleep apnea is we need to recognize the risk factor early, and then we have to set up the treatment for long-term stability, and we have to think about the structures and functions. So we have to think of what is the best way to maximize the growth potential. And we also have to think about the function. So we need to improve the muscle tones and respond. And then we need to change the growth, the trajectory. So one of the key factor, ultimate goal, is we want to make sure that our kids is able to breathe through the nose. We want to achieve the nasal breathing, and we want to promote the positive orofacial growth. So the goal is to maximize the growth potential, achieve the nasal breathing, and we want to change the direction of growth more favorable. And it has to be age appropriate, right timing, and has to be targeted treatment. So there is still not direct strong evidence of growth modification helps OSA, but in orthodontics, long time, we have studied anatomy and craniofacial growth and development a lot. So I came up with a pediatric growth modification protocol based on our literature, how we can maximize our growth potential and how to direct our growth more favorable. So the whole protocol is actually the whole day courses to talk about to detail. So today I'm gonna just focus on more nasal maxillary development. But this is the basic idea that when you wanna develop the cranial base, it's better to try the before age of 5. If you wanna grow the nasal maxillary structures more AP, more advanced, then we have to work on before age of 9. If you want to expand the maxillary expansion, the best timing is before age of like 11 and 12. And if you want to grow the mandible, the best timing is around 11 to 12. And if we meet this opportunity, this is kind of alternative treatment. And we also have to work with the surgeon and myofunctional therapy. So let's imagine, imagine the patient who has this narrow palate on the top. Probably their airway will very look different from the patient who has this wide palate, right? So do you remember PIP paste from your dental class? When you paint PIP paste on the patient's palate and you ask them to swallow 3 times, You see on the left, the PIP paste looks very fresh, right? Because the tongue never touched to the narrow high arch palate during swallowing, because there's no room for your tongue to go. Versus on the right side, you see the tongue pamper the palate nicely, and indicator paste are all washed out. So I tell my patient that the palate is the roof of your mouth, but also the floor of your nose. So whenever I see these narrow high arch palate patients, I just know that they have also narrow nasal floor. Working with the ENT, we often see this very narrow valley sign on the floor of the nose. And now we know that because the patient has a high arch palate, they probably has a very low tongue posture, and their tongue cannot reach to the roof of your mouth. And not always, but often associated with ankylosing and tongue tie. So Dr. Ginamino looked at 150 pediatric patients with a sleep apnea who came to Stanford Sleep Clinic. And he found about 40% of patients had a high narrow palate, and about 80% of high arch palate patients had a short frenulum. And this little side note, when he submitted this paper to European Respiratory Journal, their journals, impact factor is over 10, very powerful journal. They request to send the tongue photo with a ruler. So CG called me on Sunday, like, Audrey, send me the tongue photo, like as soon as possible. So that time I was checking my son's homework. I took out my iPhone. It has to be black and white only. So I took the picture of my tongue and my son's tongue and then submitted. And yay, we got, the paper got accepted. So I contributed this paper, and that's how my tongue and my son's tongue was very popular in Google search for a while. And on this photo, I show the two different way of measuring tongue. So if you're looking at on the left, this is a Raffoli method. So he measured the actual frenulum length. And if it's less than 16 millimeter, you have tongue tie. On the right side is the Colo measurement. Colo was a pediatric dentist, and he actually measured from the tip of the tongue to the insertion of the frenulum, and it's called free tongue measurement. And if free tongue measurement is less than 60 millimeter, you have tongue tie. If it's longer than 16, then you have no tongue tie. So it sounds like a 16 is a magic number, right? So when you actually communicate with medical doctors, do you know how CG, screen their tongue tie without this ruler? Do you know those like a wooden tongue depressors where the medical doctor used? Actually, the width of a wooden tongue depressor is a 16 millimeter. So maybe you can talk to your, doctors that they can still screen the very basics without ruler. So when I see this short tongue frenulum, I referred out for frenectomy. But all these patients came back saying that, oh, their ENT doctor, their surgeons say frenectomy is not necessary. They are fine. They're going to grow out of it. There will be no problem. But when you look at this tongue, maybe this one, if you're looking at the Raffoli measurement, it has a tongue tie. But if you go by Colo measurement, it's not tongue tie. How about this one? If you go by Raffoli measurement, this is not tongue tie, but if you go by Colo measurement, it's tongue tie. But isn't it? They all look like short, right? Because this tongue cannot reach to the roof of the mouth, right? So at the end of the day, we have to know that the tongue can reach to the roof of the mouth. The function is more important than absolute number. So I thought that we need very simple and easy, but functional grading tool where we all communicate between professions and be on the same page. So I decided to measure over 1,000 patients' tongue and found that the tongue range of motion ratio gave me the best bell curve, and I proposed a new functional grading tool. So what is the tongue range of motion ratio? Actually, you don't even need any ruler. It's very simple. If your tongue can reach to 80% of your maximum opening, then you are grade 1 and top 10 percentile. If your tongue tip can reach to 50 to 80%, and you are in average. If your tongue cannot reach to 50% of maximum opening, then you are grade 3 and you are bottom 10 percentile. I participate in the new pediatric dentistry textbook, and I introduced our grading tool in one of those the chapters. So now it's very widely used. So nice to know everybody using the new grading tool. After my this project, and I moved to my next project because my patient just, I measure and my patient per se have a grade 3 tongue tie. What does it mean? The patient need a surgery, or is anything is affecting in his other functions? So I started my next project because we already have a tongue measurement. So I look at their initial cast and initial cephalometric X-ray, and then see if the short tongue affect the craniofacial development. And so I compare their initial tongue range of motion ratio, and then I compare their X-rays and initial cast. And I thought that if there is their hyoid bone position and some other area also is related, but actually it's not. Interesting thing was, if your tongue especially cannot reach 50% of your maximum opening, they are very heavily affecting to the depth and the narrowness of the maxilla. After publication, our paper was very popular, so we were advised to publish the video abstract. So let's see.
We eat and speak with them, but our tongues may be even more important than we think. In a condition called onchoglossia, also known as tongue tie, the tongue is tethered more tightly than normal to the bottom of the mouth by the lingual frenulum. While this is usually considered relatively harmless, new work from dental and sleep experts at UCLA and Stanford suggests tongue mobility is critical for proper development of the jaw and facial tissues. In the study, researchers evaluated tongue mobility in 302 patients using the tongue range of motion ratio and the Kotlow-free tongue measurement. All measurements were performed in triplicate to ensure consistency and accuracy. Each participant also had dental casts made and X-rays taken to capture anatomical features of the teeth, mouth, and face. Most people had normal or only slightly diminished tongue ranges, although some had more severe restrictions. Reduced tongue mobility correlated with a smaller ratio between the inner canine width and the canine arch length, which may indicate underdevelopment of the upper jaw. Limited tongue movement was also linked to having longer soft tissues at the back and roof of the mouth. Longer soft palates are common in people with obstructive sleep apnea. It's possible that people with reduced tongue mobility may breathe with their mouths open more or swallow abnormally, which may help elongate the soft palate. The longer soft palate could also arise from reduced tension holding up the soft palate due to narrower maxilla. Contrary to previous suggestions, however, no association was found between ankyloglossia and position of the hyoid bone, a horseshoe-shaped bone in the neck that moves with swallowing, chewing, and breathing. The group also found no relationship between decreased tongue mobility and the classification of malocclusion, which 2 small studies previously reported. But the lack of evidence for these associations doesn't mean they don't exist. While this study is one of the largest of its kind overall, there were few volunteers with severely restricted tongue mobility or with abnormally aligned teeth, which may limit some of the findings. Nevertheless, the results do suggest the tongue plays an important role in development of the mouth and face, and if the tongue cannot move freely enough, people risk developing high-arched palates, a narrow upper jaw, and longer soft palates.
So this is published in the YouTube, so feel free to look and share with your patient and colleague. So after this publication, I got a lot of requests that we need to come up with a more functional measuring tool, because when we swallow, we're supposed to lift up our middle and back portion of the tongue and seal the back throat. That's how we create the negative pressure and swallow. So the middle to back portion of the tongue is actually more important in terms of the function. And sometimes we're going to miss out a lot of patients who are maybe able to lift up the front portion, but they're not able to raise the back portion. It's called posterior tongue tie. So we propose now the new and improved version of classification of ankylosing, and Dr. Zagi was the main task for this project. So step one, we ask the patient to open your mouth as wide as you can without pain and discomfort, and we measure the opening. And then step two, we ask the patient to lift up their tongue up behind the upper front teeth and open your mouth and measure the opening. And then step three, we ask the patient to make a click sound with your tongue and then make a click and hold. So the tongue is up in the roof of the mouth, and we measure mouth opening. And then we run the ratio. So the tongue mobility, the original one on the top, with the anterior tongue mobility grading scale, tongue range of motion ratio, but we added to the posterior tongue mobility grading scales, and we proposed a new functional classification. So we kept our previous anterior grading scales, but we also added the posterior grading scale. So the posterior grading scales, basically your palatal suction opening is more than 60%, then you are grade 1, and the lingual palatal suction is between 30 to 60%, then grade 2, and less than 30%, then grade 3, and so on. And we also subcategorize this grade 2, 2A, 2B, 2C, 2D for those clinician and researcher who perform any treatment for tongue tie and they want to measure the minor differences. So the 2018 to 2020 at the UCLA Pediatric Dentistry, we actually measure, we actually see the probable sleep bruxism is associated with any other the sleep disturbance, because we see the kids grind their teeth all the time. So what we did is we look at the patient's the mixed dentition kit, and we look at their dental wear, and also I think questionnaires from the parents that they're grinding or not. And then we also measure their sleepiness scale, and then also we measure their craniofacial structures. And we found that this we call probable sleep bruxism, because we didn't do any sleep studies, so we call probable sleep bruxism associated with impaired nasal breathing and habitual mouth breathing and restricted tongue mobility. And among these patients, the functional ankylosing was found to be one of the most important contributing factor for the bruxism, and it was published about several months ago in the Sleep Medicine Journal. Interesting thing was with the same data, when we split our data to nasal breather and mouth breather, when we look at the kid who is a mouth breather, we found a very low incidence of bruxism. But then if you're looking at the mouth breather, we see the tongue actually play very important role while they grind their teeth or not. And if we actually if you're looking at those population who has mouth breathing, ankylosing, and tonsillar hypertrophy, all three factors, almost everyone has a bruxism. So our result further show there is a synergistic effect between mouth breathing, ankylosing, and tonsillar hypertrophy for bruxism, and we thought that was very interesting. So people asking, oh, so my kid has a tongue tie, And tongue tie is the main etiology for maxillofacial underdevelopment because of my paper. Actually, it's not, because after I published my paper, a lot of people kind of overanalyzing and then overusing that, the tongue tie is the only factor or major factor to develop a narrow high arch palate. And once you do tongue tie release, like all of a sudden their palate gonna develop. It's actually not. So me and Dr. Zagi actually went back to our data, and then we actually calculate, and we found that is restricted tongue mobility account for 7.6%. So only 7.6% in narrow maxillary arch, not 100%. So this is how complex this area is. So tongue tie is one of the multi-factors to alter the maxillofacial development, but not the only factors. So that's why sometimes you see the patient has a grade 4 tongue tie and very short tongue, but no swallowing issue, no speech issue, and well-developed palate, because their tongue sometimes can compensate well. And people ask, oh, so when we do the tongue tie release surgery, they're gonna improve the sleep quality, the sleep apnea gonna disappear. Yeah, maybe contribute a little bit, but maybe not. So far, this is the only paper shows that after frenuloplasty, the patients feel better in terms of snoring and sleeping. But this one, even this one, they actually did a frenuloplasty with a myofunctional therapy. So don't expect that you just release the tongue tie and then all of a sudden the patient's sleep apnea disappear, because the tongue tie affect the function. At the end, we want to get the function back. So in order to get the function back, we have to work with the myofunctional therapy. And in this paper, they did a frenuloplasty with a myofunctional therapy, and it shows that 91% satisfied and 78% they feel improvement on the mouth breathing, and 73% they feel improvement in snoring. But this one is only based on the only questionnaires. There was no sleep study based. So still very controversial. The most effective treatment of maxillary deficiency in children is rapid palatal expanders. RPE transfer the force to the maxillary bone very fast, which separate the middle palatal sutures and create the space between incisors. Definitely a landmark paper is Dr. Paola Pirelli's paper. I personally like this paper because I know Dr. Pirelli, who is like my godmother in the field, told me how difficult it was to publish. And when he goes to his meeting, often she's only dentist among MD and only orthodontist and only woman, and she has to convince them how orthodontic treatment can improve the medical condition like OSA. And finally, like after many obstacles, she published her work to the most prestigious article, Sleep, in 2004. And here she showed 31 children shows their sleep apnea cured after expansion. And she followed up the same group for 12 years and also published the following paper showing that the result was stable. Expander treatment still criticized that the level of evidence of most of this article is not very strong. However, if you're looking at now, it's about 24 to 25 articles out there, including like 3 systemic review and 1 randomized control. They all shows that expander improved OSA symptoms. Then make us think that there is something there, isn't it? As orthodontists, we use the expander between age of 7 to about 14 to 15. But how about before or after that age? Can we still expand the maxilla to improve the OSA? Does OSA happen to any age? So I'm also a pediatric dentist. So I look at the AAPD guideline and then found this statement. So if there is, during primary dentition age, if there is any habit or crossbite, and if it is predicted not likely to be self-correcting, then we should address the problem as early as possible. Because of Briella is 4 years old and no orthodontist, wanted to treat her, so she came to my office at 6th to 7th opinion. Even though she's a little 4 years old princess, she pointed out her face and told me, Dr. Audrey, my face looks crooked. Do you think this functional shift will be self-corrected? No, right? Then what are we waiting for? So before it was hard to take impression of our little one, but now we have intraoral scanners, so we can easily scan children's teeth and make the 3D printing model and make appliance and very easy delivery. For Briella, I used a bone double expander to deprogram her muscle because she had a very severe functional shift. And during primary dentition age, I do very slow expansion, so 1 turn every other day or 1 turn every third day. And 3 weeks after I delivered the expander, I got a phone call from her saying that her expander fell off. So I expected another unhappy crying kid, but she turned out to be happiest emergency patient. She told me that, Dr. Audrey, my face came back to normal. And you see the kind of skewed, altered facial profile actually came to the center. And this is the power of early treatment, starting early. So I glue back her expander and then finish expansion in 2 months and then follow up the 4 months. Interesting thing was she had a grade 4, like a kissing tonsil before, and her family didn't want to do any surgery. So we just expanded the maxilla, and then we tried to establish nasal breathing. And then 4 months follow-up, we found that her tonsil size shrunk. And I see this kind of cases over and over. This is another case, actually, the Stanford, one of doctor's kids, 5 years old, was a full class 2, very narrow hierarchy palate, and very severe overjet. So I put the expanders, and then COVID happened. So after the expanders, I gave her, the only thing I gave her was expander, and then I mailed what we call Healthy Start Heavy Corrector appliance. Like a heavy corrector is kind of soft, kind of plastic removable appliance to design to improve the bad oral habits and train the tongue postures and proper swallowing. And I mailed another heavy corrector during the COVID, and then I followed up in a month, and all of a sudden my full class 2 was corrected. And this is my retention protocol after I finished the expansions, especially the vertical growers. I actually put some we call lingual arch, so they prevent eruption of the molars and also maintain. The interesting thing was she had almost like a kissing tonsils, and she had a big adenoid, and her dad is ENT, so they scheduled to remove those adenoid and tonsil. But then after we do the expansions, on the right side tonsil almost shrunk to normal, left side is still there, and then adenoid is almost gone. And we look at her airway before after. This is only like 8 months. We actually only thing we did is expansions and healthy start. And we see like even tonsil size actually has shrunk dramatically. So they couldn't do the surgery because of COVID, and they end up canceling her surgery. And I see this kind of case again. Her cases, that we measure the volume that adenoid and tonsil was actually shrink more than halfway. So currently, the Stanford and UCSF ortho department, we are collecting all those the cone beam CT cases after the expansions, and we actually measuring the volume of tonsil and adenoid before and after the expansions, and will be published very soon. But we actually see pretty amazing result. So stay tuned. So let's go back to the expansion. So after age of 12 to 15, that our middle palatal suture is a little bit closed, we used to do surgically assist RPE because the suture is closed, so we basically creating suture by surgery. But if we're using those tooth-bone expanders, in children about 50% and adolescent about 65%, we still get dental expansion. So the new concept is, how about now we are using mini screw and also, so why we incorporate the TAD to the expanders, so we're not losing our forces through the teeth and alveolar bone. We actually apply the force next to the sutures directly, so we get more skeletal expansion. And I started using this the MARPI concept about 8 years ago in my practice. And the patient is telling me they can breathe so much better. And I found out that I was able to open up the suture without surgery if the kid is young, like adult, like late teenagers. I show you one of the non-surgical MARPI case with a face mask. The Haley came to my office with a cheap complaint that my Christmas wishes past 13 years is to have 2 front teeth. Haley is a 13 years old female with a solitary median maxillary central incisor syndrome. So this syndrome has the characteristic of multiple midline defect through the midline of face and body development. So she has nasal malformation, asthma, sleep apnea. And because of midline defect, she has only 1 incisors on primary dentition and permanent dentition. So she always had a 1 front incisor. And also she has multiple missing permanent teeth. She had a phase 1 ortho history with an expander and face mask. So she could be worse. But now she's ready for phase 2, and no orthodontist wanted to treat her in her town, so she's driving like 7 hours to see me. You appreciate that she has a midfacial deficiency and the narrow palate. So I decided to use the mini screw assist expander MARPI with a face mask to develop the mid face. So whenever you want to develop the mid face, more like anterior direction, after age of like 10, after age of 9, regular expander really doesn't work. So you need to use the mini screw assist expander to get more skeletal expansion. For her cases was special because she has so much sinus issues. So this kind of cases, I have to use the modified MARPI design because she had a very paper thin, the palate and sinus problem. So, you have to be careful that you don't want to put a lot of screw and puncture to the sinus and the nasal cavity. So I designed the custom design where the screw holes where there are enough bone. And unluckily, other 13 years old, she has some pain and discomfort. So I had to stop expansion about 7 millimeter on the screw level. But with only 7 millimeter expansion, she was extremely happy and breathed through the nose so well. And this was an accidental finding. I don't see it all the time, but we saw the left sinus was kind of clearing up after I expand with the MARPI. And I used the face mask to develop the middle face. And, I work hard to give 2 front teeth before the same year Christmas. And using MARPI with a face mask for just 4 months, we were able to develop her middle face at age 13. And her apnea hypomnia index, which is basically how many times you stop breathing per hour, reduced to the normal. And you see how we actually change her profile in only 4 months. So I brought this MARPI concept to Stanford Sleep team about 7 years ago. And I told them, I found the solution for adult OSA patient with a narrow palate. I think I can expand all adult palate without surgery. Let's expand them, send me all the patients. And then I tried, and my first 5 cases was all those like very severe sleep apnea, middle-aged man who has a narrow palate and was scheduled to get the maxillomandibular advancement surgery. And I tried the MARPI, and then I failed. And I failed again with many side effects, which some of the side effect was unforgettable. Forgetful. And I realized the MARPI is not always predictable for especially old OSA populations. So with the demands of a predictable adult expansion, we combine with MARPI and then old school like osteotomy, but we can actually do more minimally invasive surgery. And we actually put these two powerful tools together. We found that amazing expansion that we never saw from MARPI or SARPI alone. And we named DOME at Stanford. So this is my like kind of maxillary expansion protocol for OSA. It's a little bit different from normal orthodontic expansion protocol. I tend to use meniscal a little bit earlier. I use the MARPI around even age of 10 if the patient has a sleep apnea or sleep disorder breathing. And if you want to, again, if you want to develop the mid phase forward, I actually use the MARPI a little bit younger. And I use the DOME for adult OSA. So I tell my patient that you have narrow hierarchy palate, and I will make your palate to nice Romanesque dome shape. And the procedure you're gonna get is named DOME. Then all my patients remember what kind of procedure they're gonna get. And DOME stands for distractional osteogenesis maxillary expansion. And no bias, but hierarchy shape architecture is a Princeton University, and nice dome shape architecture happened to be Stanford. And we developed the DOME protocol at the Stanford, and we reported our first 20 successful cases to Otolaryngology Journal about 4 years ago. And the response was amazing. 5 years ago, there was the biggest World Sleep Congress meeting in Prague. We had a 7 symposium, and we just talk about the DOME in different aspects. We also create a new chapter for Dr. Friedman's sleep apnea textbook, and that personally, this was the most rewarding moment for me that I proposed one of the orthodontic treatment to the medical field, and it got recognized as a medical treatment modality. And we also shows that the DOME also affects the internal nasal valve, which is the narrowest airway in the nose. And we look at the 75 subject and confirm that DOME as a new treatment alternative for adult sleep apnea. And we published our article in Sleep Medicine Journal last year. And was last year, Sleep Medicine published this editorial, Expansion of Maxilla in Adults with OSA, Myth or Reality. And they introduced my paper and mentioned that the specialty of orthodontic has been reluctant, but when the evidence-based literature demonstrates success, it is time to change the paradigm. And the article invites us to apply an older tool in a new way to treat the OSA condition. So it was very exciting. I also participate Dr. Kibam Kim's new OSA textbook. It finally published last year. And this chapter on the MARPI technique for sleep apnea, I compare all different type of MARPI, because if you go to different university, different country, their professor using their own MARPI design, and they claim that their MARPI design is the best. So here I compare all different type of MARPI design, and I discuss about each design's pros and cons. But what I learned was there's no such a design that one size fits all. Patient has a really narrow palate, need help the most. And often those ready-made MARPI cannot really fit it in. And also my patient, a lot of my, especially those grinder and hierarchy palate patient has a palatal tori. And also I get a lot of these patients with a cleft palate and multiple impacted teeth. And I have to be creative to come up with a custom design to help these patients. So most of those cases, we overlap the intraoral scan and cone-beam CT, and we perform the surgical simulation. And we measure the ideal screw length, and which give the bicortical engagement but not puncture the nasal floor. We also now we do planning for different cuts, and we actually using those navigation systems. In average, we expand about 8 millimeter at screw level, and we are able to get about 6 millimeter in the nasal floor width within 6 weeks. So it's quite a lot. And working in Silicon Valley, we also needed to launch the new version. So we came up with the Dome Mini and Dome X. And Dome Mini is not a small dome, is actually minimally invasive via nasal endoscopy. So all the incision is inside the nose. And we also use the navigation system. So now we are making everything custom, because some patients need more anterior expansion, some patients need more posterior expansions, some patients need more like small expansion, some patients need a more parallel, bigger expansion. And some patient has no bone on the palate, some of patient has like so thin on the palate. So we now customize for our expander design and also surgical design. So some patients get the full cut all the way from piriform to the pterygomaxillary disjunction, versus some patient we do very minimally invasive, like a middle palatal cut, or just get rid of the zygomatic buttress interference. So now everything is the design with a navigation system, so we actually can go blind as well. How much do you expand on maxilla? This is my very old but interesting cases. I share with you this interesting dome surgical case. The patient was a Stanford physician, and he had what we call upper airway resistance syndrome, where there's no distinct apnea, but patient has a lot of breathing disturbance and very symptomatic. When I saw his teeth, it doesn't look like he's narrow and no posterior crossbite. So I told him expand to about 6 millimeter and then come back, and we go from there. And then he showed up with a 9 millimeter extension with a 15 millimeter diastema. So like, oh my, doctor, you need to listen to doctor's order. And when I asked what happened, he told me when he turned the key, he was sensitive enough to feel the difference real time, and he felt like he's gonna have a good night's sleep. So he got addicted. And until now, I have about 3 cases, like 2 doctors and 1 engineer who doesn't listen to doctor's order and doesn't stop turning the key. And so it took about 2.5 years to close all diastema and finish his cases. But when I look at his initial and after expansions and the final record, you see the before X-rays. Patient never were able to breathe through his left nostril throughout his whole life. He was never able to breathe through the left nose. And after expansion, you see the left side nasal passage was developing. No wonder he felt so much better. And after like 2.5 years, you see how nicely we developed the left side air passage. The awareness of sleep disorder breathing has been growing fast the past years, but I still see huge disconnect between professions. Like working with the Stanford sleep team, I had many chances to go different sleep medicine. When I go to sleep physicians meeting, they focus on sleep physiology, but they are not really connecting their finding with the patient's anatomy. If you're looking at the sleep study, they actually don't look at any anatomy. They are not trying to correlate anything, any physiology, the data to the anatomy data. If you go to the sleep surgeons meeting, they talk about 5 different ways of cutting tongue and chin, but they don't know the dentist or orthodontist also can change airway anatomy. But I think the most important thing is when you go to the sleep dentist meeting, often they are selling one magic appliance, like one technique, and they advertise it will cure all sleep problem. And then only result they are really showing is before and after combine CT airway volume measurement with a beautiful color mapping. And then like before their airway volume was this much, and after use this one magic appliance, our volume improved this much without understanding the sleep physiology. So we thought that sleep apnea treatment was pretty simple all the days. Like sleep apnea is just from the blockage of airway. But now, in fact, the current thinking is much more complicated. It is interaction of multiple forces. So actually, this is one of the important slides. And after I finish my presentation, hopefully you understand the pathophysiology of OSA. The obvious one is anatomy. Both the local and remote anatomy play a role. And the local one is obvious. Anything in the way of airway, which contribute to blockage of airway, such as tonsil. But then there is also distal factors. But then also there is this tissue property, which is collapsibility of tissue itself. And there is also muscle tone. When the losing tone is a part of sleep. Like imagine you are like, if you are nodding your head, like losing tone is one of those like a physical manifestation is losing tone of your posture muscles, and your head drop forward during nodding. And then when you wake up, your head pops up, right? And also there is a aspect of neural control, which related to sleep phenomena itself. And then also there is a loop gain, which is like a drive of pump, and like a airway engineering principle is also come into the play. And also there is a behavioral factor, such as a breathing pattern. Are you breathing through the nose, or where is the tongue postures? Some orthodontic friends challenging me, like, Audrey, expander is not working for OSA. And they brought this kind of article. There is about 4 articles, Angle and AJODO journal out there, showing that after expansion, nasal pharyngeal airway volume doesn't change. So a lot of papers showing that their volume change, but there are some papers that it doesn't change the airway volume, and they believe because of airway volume doesn't change, expander is not working. So really, okay, first, then let's look at the airway volume. Is it reliable? Which airway is more favorable? Which one? It's actually from my friend, Mariana Ivan. She took her own headshot 3 times during inspiration, expiration, and swallowing. And we see how we can be fooled by breathing and tongue movement. How about which one? Which one is more favorable? Which patient has OSA? It's actually me. I took my own CT scan with one chin up and another one with the chin down. And when I measure my airway volume, the change is not 20-30%. It's actually 2-3 times difference. It's a huge difference. Because our airway is dynamic. Our airway is constantly moving from breathing, swallowing, and postures. So Dr. Liu has shown that this is a 2 group. Their age and BMI match. And then when they look at on the static measurement, they had the same airway volume. But when they run the dynamic sleep MRI, and when they turn the airway to the frontal view, you see on the left side, their pharyngeal airways maintain, which they fall into mild sleep apnea, versus on the right side, you see their pharyngeal airways collapsing. And they're under the category of severe sleep apnea. And this pharyngeal airway muscle collapse is one of the most important factors associated with a severe OSA. Because the airway has no supporting structures. And if you're looking at the pharyngeal airway, there is no supporting the bone. So muscle collapsibility and muscle response is the key. So quick overview of anatomic basic of the airway, just make it very, very simple. You can think about the nasal airway. The nasal airway is surrounded by bony structures. But then if you're looking at the pharyngeal airway, just collapsible too. And I'm gonna go over very important concept. It's a little boring concept, but it's very important whenever you read any sleep medicine journal. They will all talk about the peak rate. It's a critical closing pressure. So what is the peak rate? Peak rate is the airway pressure where the airway collapses. So at the end of the day, our ultimate goal is to make sure that our airway not collapse, right? So imagine there is a rubber balloon. Rubber balloon is so collapsible, so it's already collapsing at the current pressure, right? So in order to not collapsing, we have to blow the positive air, right? That's how the CPAP works, continuous positive airway pressure machine. They are basically blowing the air. So the peak rate of this air balloon will be positive, right? But then let's imagine our garden hose. Our garden hose is so stable that it's not very easy to make it collapsible, right? So in order to make it collapsible, I probably, put the vacuum hose and suction the air to create the negative pressure to make it collapse, right? So the peak rate of this garden hose will be negative, right? So which one has a better airway? The garden hose, the foam airway is better. So the more negative peak rate is the more stable airway. So our goal is to make our airway has more negative peak rate, right? So when the patient asks me, Dr. Yoon, how expansion improve OSA? I usually tell them, okay, look at the upstairs and downstairs of the palate. So if you're looking at the nasal pharynx, the nasal airway is surrounded by bone. So when we do expansion, we expand the nasal cavity and we decrease the resistance to the airflow through the nose and we improve the nasal breathing. But how about the oral cavity down there? Dr. Iwasaki found that actually it is a secondary effect of extenders. So it takes about 6 months, after the expansion. What we did, we create more space for the tongue. And what happened is the tongue postures actually change. The tongue has more room to go up and then forward, and that's how we create more airway. It's not like we are stretching the airway bigger with the extenders. Actually, what we change is the tongue posture. We make more room for the tongue and tongue posture change. And that's how we open up the pharyngeal airway. That's why some of the paper doesn't show the pharyngeal airway change. So depending when and how you measure, pharyngeal volume may not change after expansion. But remember, there is all like 24 paper shows that expander improved the OSA. Then what is the real mechanism? Like how maxillary expansion improves OSA? So I designed the different studies, computational fluid dynamic study. Our CFD study was superior because we had a biologic data such as the renal nanometry, and we also had a physiologic data including sleep metrics. So we ran computational fluid dynamic, calibrated with the renal nanometry to make more realistic condition. And we evaluate the nasal airway and pharyngeal airway. And then we try to correlate the data with the sleep physiology data. So what we found was before expansion, before dome, there was a lot of obstructions around the internal nasal valve area, which is the narrowest part of the nasal airway. So imagine there is some obstruction in the nose. The airflow velocity go high and create more air turbulence, which creates more negative pressure. And then negative pressure creates more pharyngeal airway collapse. But what happened after the extensions, after the dome, we got rid of this nasal obstruction. Now the the air velocity slow down, more laminar airflow, and then airway muscle become more relaxed and low negative pressure at inspiration and become more stable airway. So if you're looking at this dot line, the dot line is, if you're just looking at the airway volume as CT scan, it just expand a little bit, it increased a little bit, but not much change after expansion. But when we run the CFD during inspiration model, we see before expansion, there was a lot more airway collapse. And after expansion, there is a lot less airway collapse. What we changed was we changed airway collapsibility peak. So after expansions, yes, we changed anatomy, craniofacial structures. But what we did, we also changed airway collapsibility. We changed the peak rate, and we also changed the tongue postures. And we convert the patient to nasal breathing pattern. And all these interactions make our patient OSA improve. And this is how expansion improve OSA. It's not like we are making airway just stretch to wider. So I'm going to talk about the sleep surgery a little bit. So this is like an original Stanford protocol. So it was established by Dr. Rowley, Dr. Powell and Dr. Rowley at Stanford. Basically, their ENT protocol was, okay, the patient come for airway issues. They look at the site of obstructions, and then basically they just cut all the soft tissue. So they call UPPP basically the palatal surgery. And then if the airway obstruction is more lower, then they do genio. And then see it works. And if not working, then okay, now we're going for MMA surgery. So MMA surgery is basically the orthodontic surgery. We cut upper maxilla and mandible and then bring upper and lower jaw forward. But now at Stanford, we look for site of airway collapse using, we call drug-induced sleep endoscopy. So we look at not just where the airway collapse, but also look at the behavior and configuration of airway collapse. So this is like one of those examples. So if you look at here, so if I orient it, you see this is a tonsil. So during the sleep, you see tonsil is kissing, and this is the airway. So for these cases, probably tonsil needs to go, right? Versus here, you see this is behind the tongue, and during collapse, the tongue is actually falling back. So this is, we call AP collapse on the tongue base. And this is actually good case for oral appliance. So we can bring the mandible. Here is around the velum level, is we call concentric circumferential collapse. So if the airways collapse like this, expansion not gonna help, oral appliance not gonna be enough. The patient needs a way more than simple surgery. Like usually we go directly to MMA. And when there is a lower pharyngeal wall collapse, do you remember those MRI studies? This is actually a good candidate for MMA. And the epiglottis collapse, which is not very common. It's very controversial. If you go to the ENT meeting, they're gonna talk about different way of cutting epiglottis. They cut halfway or only cut to the side. But when what we found is when we change their dentition orthodontic, with the expansion, sometimes the airflow change and their occlusal plane change, and we have a few cases that we are able to correct the epiglottis collapse. So now we actually do more complicated algorithm. So it's this is like a Dr. Lu at the Stanford. He developed the sleep surgery algorithm and he published in many textbooks. So I mean, this is like it's the whole day lectures and stuff. But basically, when the patient comes, we actually see we through this drug-induced sleep endoscopy and then see where is the obstruction, and we see what kind of behavior of airway collapse. And we actually put dome is under the nasal surgery, because we think the dome is actually changed for the nose structures. And if you're looking at here, if the patient has a lateral pharyngeal wall collapse or circumferential collapse, we don't want to waste the time on this. We actually go directly to the maxillomandibular advancement surgery. So this is like our typical summer MMA surgical case. So this patient had a tonsillectomy and phase 1 and phase 2 ortho, but the patient still very symptomatic and sleepy. The patient had very severe sleep apnea when he was little, and after tonsillectomy, adenoectomy, and radiofrequency turbinate, he got a little bit improved, but the patient was very, very symptomatic with excessive daytime fatigue, and he couldn't really focus at school. You see, because of a long ortho treatment, his dentition is kind of class 1, but if you're looking at his face, it's very definitely mandibular deficiency, very class 2. His orthodontist tried to grow the mandible for 6 years using twin block, bio block, and full braces. But at this moment, the patient was very symptomatic. We decided to do the MMA surgery. So at the Stanford, with the modern MMA technique, we don't just push the upper and lower forward. We do counterclockwise rotation to bring the mandible forward. Imagine he had a class 2 profile. So if we just bring upper and lower together, because the bite is a class 1, we're gonna just maintain the class 2 skeletal relationship. So what we do with we do a big counterclockwise rotation. So very minimal middle phase change, and we are able to maximize the airway stability. So this kind of cases is like our quick summer MMA case that we throw the bracelet the first week of summer vacation, and then next week we perform the MMA surgery, and then we remove the braces in 3 months, and the patient sleep apnea cured, and he go back to school after the summer vacation. So then a lot of people ask, how can you do MMA for bimaxillary protrusion? Because when Dr. Rowley originally published the MMA case, he published that we have to bring the maxilla 10 millimeters, maxilla and mandible 10 millimeter to make the MMA case efficiently. So imagine they already have bimax case, and if you bring upper and lower jaw 10 millimeter, we're gonna make their face more like ape feature, more like a monkey. So no, again, we do counterclockwise rotation, but we also play with the chin. It's not genioplasty, we call genioglossus advancements. So what it does is we actually not just cutting the chin. We actually try to capture where the capture the genial tubercle, where the genial glossus muscle attach, and then we actually bring this chin forward. So we also make the faces more harmonious, but also we actually maximize our airway improvement. So this patient this is the before and after MMA surgery, and sometimes we can actually make the face more balanced. So whenever I plan MMA surgery, this is like, my ongoing debate, how much, what kind of movement will give the patient's best airway as well as the best aesthetic and occlusion. Is there any way that, we can simulate that? There are a lot of 3D simulation is under research right now, but current available software still is about the Photoshop level. But we know that Hollywood 3D animation movie.
Dial is the footballer, but it's good enough to.
They all
how natural their 3D movement, remember? But in order to make that level of accuracy, millions of camera, high functional computer, and lots of labor were required. But now we have, iPhone with like a multiple camera. And how about we can use our iPad and iPhone to scan patient's face within 30 seconds. And then we can save the accurate information less than 1 megabyte. And maybe we can send to the friend and doctors. And maybe we can compare my face and the person I'm interested in, or the person I want to look like. And this is my 3D face overlapping with my sleep surgeon, Dr. Lu. And how about we can measure the real time, the area of our interest. And I found out that my nose is bigger than Dr. Lu, and Dr. Lu's eye is bigger than mine. How about we can add the muscle functions such as muscle insertion, muscle behavior, and we can make our movement is more realistic in 3D. And we can also apply this technique to our surgical simulation to see how each bony movement affects the face. And even better, after surgery, we can also look what really happened after surgery, and we can compare. And somehow we can predict the airway, not the airway volume, but somehow we can predict the peak rate and how much movement of their chin or jaw actually is enough to relieve the burden of the airway. And somehow we know that how much movement is related to pressure airway collapse, and it's just like how much movement is just enough to relieve the burden of patients. And this is our dream. This is not real yet, but we can really design patient-specific custom airway in the future, and that's our dream. So my message today, there is so much important role we can play as a dentist and orthodontist. We have the privilege to design and develop the patient's anatomy and airway. We can make the straight teeth, beautiful smile, ideal occlusion, but we also can make our patients so much healthier to different level that you never imagined before you could. So I hope I inspire today to open your heart to airway. And if you have any question, I will answer. Thank you so much.
Thank you, Dr. Yoon. There are a few questions. And I thought some of those cases were amazing. You literally changed those people's faces. So those were awesome. But here are some of the questions. The first one was, do your patients ever ask you about mewing?
Yes.
And what are your thoughts about it?
Yes, the answer is yes. And actually, I don't see any problem with the mewing. And actually, the concept is right. I don't know, doing viewing change the shape of face that dramatically. I know that the YouTuber, um, uh, YouTuber, but the basic idea is the viewing is where your tongue to the put the palate, and that's actually the ideal spot of your tongue. And maybe everybody can try to do. Maybe can you put your tongue to the roof of your mouth and try to breathe through your mouth? You can't, right? So in order to breathe through your mouth, so if you're a mouth breather, your tongue posture always go drop. It's what we call low tongue posture. So whenever you see the low tongue posture, number one, first thing I suspect is mouth breathing. So in order to breathe through the nose, your tongue has to go to the roof of your mouth, and the mewing is kind of that concept. And I mean, I don't tell them that they're gonna change their shape, but um, if they are into mewing, actually, it's a good for establishing nasal breathing.
The second question was, what if there is a relationship between clenching and sleep apnea?
That's so hard to talk. So it's more like not really clenching, it's more grinding. And the grinding and clenching, and then TMJ and sleep apnea is actually very well related. So it's actually a long talk, but
You'll have to come back for your next one.
yes, they are related. And a lot of time when you cure the sleep apnea, so it's again, it go to the paroxysms and the clenching. So when we cure the sleep apnea, there is a good chance that their clenching and paroxysm habits improve. But there's a lot of psychological components, so you cannot really guarantee. So when you do the paroxysm, there is a big component of airway, and there also a big component with the psychological issues. So they're all kind of connected. But yes, they're connected.
I think this member asked basically a follow-up question to the other member. He said, mouth breather has higher relationship with bruxism than nasal breather. Is bruxism more related with mental stresses, and do they have any co-relationships? I think you kind of answered that.
Yes. So I mean, when the patient just come and there's no other problem, and they say, okay, I have a bruxism, and can you cure me? And basically, that is a two major component. One is breathing, and then one is psychological. And there is a lot of cases that we cure their sleep apnea and they still grind their teeth. But there is a good cases after even like throwing the simple oral appliance and they just stop, grinding their teeth. But there are a lot of those stubborn cases as well.
The next question is, what is the age limitation for the use of just MARP in adult males and females?
I know. So there so I know I have a lot of cases. I think I'm also writing a paper with a UOP ortho resident. I think hopefully publish the data this year. So we gonna give you more like a percentage of success rate. I put it that way. So up to the age of 20, almost like 100% of my MRP case success in terms of, but also it depends what is you call success. So if your success is the suture opening, then up to age of 20, almost 100%. I think the success rate dropped dramatically after age of 25 for the male. So after 25, I have still several cases, even like early 23 or 24. The success rate goes down, but also depending on the anatomy. Some patient has extremely thick the palatal bone, or some patient has very thin bone. Those actually doesn't work that well. Female tend to work better. So I have a lot of successful cases for female, like even like 45 years old or like even 30. But then also I fail on female as well. So is really when the patient come in and they really want to try the MRP, I really tell them that success rate is not 100%, especially after age of 25 for male, and then after like age after 30 for female. But then still I fail few 20s female as well. So I tell them the success rate is not 100%. If you want to try, I'm willing to try. But if the patient is over like 40 years old male, I will probably discourage. And I will try maybe some 30 for the male, but the success rate is not that high.
Yeah. Another person asked, well, they asked two questions. One question I think I can answer. At what age should a pediatric patient be referred to an orthodontist if an airway issue is suspected? What's the best way to find an airway aware orthodontist?
I know that is tough to find the airway aware orthodontist. Hopefully, because I'm teaching airway course for UCLA Ortho, UOP Ortho, and UCSF Ortho this year. So hopefully new grad is in our future are more open to the airway and they're more familiar with the airway. I mean, so in terms of age, it's actually any age that we need to address the problem. The problem is most of orthodontists not comfortable treating really little kids. So it depends on the orthodontist comfort level. I mean, I'm pediatric dentist and orthodontist, so I don't mind treating
Right.
2 years old, 3 years old, 4 years old. But most of orthodontists, even though they know maybe they're airway orthodontists, maybe their practice not ready for 3, 4, 5 years old. So I think it's really depending person to person. And if you're a pediatric dentist and you are familiar, I think I encourage they actually treat the pediatric patient, and they can refer once the patient becomes 7, 8 or more manageable. But pediatric dentists way better in terms of behavioral management.
Yeah.
I guess it's really person to person, and I treat even 2 years old if
Yeah.
they have a sleep apnea.
Another member wanted to know, with the palatal expansion, why did the tonsils shrink? Did the inflammation reduce?
Yes, definitely it's inflammation reduction. So we are almost finishing measuring, and then we hopefully we can publish the paper. And then I think our next paper, we're gonna talk about which case actually shrink and which case it doesn't. And I see if the patient has a persistent like allergy or some other issue with the expansion doesn't really work, but somehow we are able to establish the nasal breathing, and I think the inflammation reduce and those tonsil and adenoid shrink.
And the last question I see is, my patients often complain that their kids are grinding their teeth. The kids are in age range 5 to 10. What is the most likely reason?
Yeah, so again, it's there are the most recent our paper, we thought that they are very related to mouth breathing. And also there was some component of the short frenulum. There are also airway issues when they have big tonsils, big adenoid, they to grind more. But also there is a psychological issue. So basically same thing is the two main reason is psychological issue and the airway issues, and then a little bit of tongue short frenulum issues.
Awesome. Well, I think that's it.
Yeah, I was on time.
It's great to see you again, even though we can't be together. And thank you. Now we can all say we've been at UCLA because Dr. Yoon's at her office. So we can all say we went to UCLA today. And I'm sure Dr. Yang wants to say something as well.
Well, yes, thank you very much for a wonderful lecture, and look forward to see you again soon.
Yeah, hopefully next time we actually see each other in person
Right,
and have dinner together.
right,
Well,
Right.
nice.